Hi, I'm Dr. Thanai Pongdee. I'm an associate professor in the Division of Allergic Diseases at Mayo Clinic in Rochester, Minnesota. In this video, I'm going to be discussing the importance of multidisciplinary management and monitoring of patients with non-advanced SM, and how to ensure your patients with SM are accessing all their appropriate care pathways so that their SM is well controlled and their quality of life is optimized. Patients often see multiple specialists before being diagnosed, and we see referrals from multiple specialties into our practice for either questions of SM or actual diagnosis of SM and need further clarification of their diagnosis or treatment plan. We do see some common themes among these referrals, and I'll start with the list of specialists that we often work with. Dermatology would be a key one because the majority of adult patients with SM do have skin lesions, in particular urticaria pigmentosa. So these lesions can be, they are chronic in nature and may be somewhat progressive in quantity or body surface area. So eventually patients may start seeing a dermatologist, not wondering what these spots are they problematic, if anything needs to be done. And that often leads to a skin biopsy from a dermatologist and a subsequent diagnosis of urticaria pigmentosa or maculopapular mast cell disease is made, and we will see those referrals. So here we have a presentation that essentially skin symptoms that needs further evaluation. What's often helpful from our dermatology colleagues, if they go ahead and order a serum tryptase level prior to the referral, that can be very helpful. We have some that we have close relationships with that will actually order peripheral blood for high sensitivity KIT mutation testing. And they've already somewhat risk stratified this patient for SM before they reach our front door. And again, that can be quite helpful. Again, not necessary, but with hopefully the knowledge gained from this webinar, those are things you feel more comfortable ordering and pursuing. We see a fair number of referrals from emergency departments. These are typically from anaphylactic events. So again, many patients with SM are high risk for anaphylaxis, especially those that have anaphylaxis to stinging insects. So those we know have high risk of likelihood of having SM, and those patients present in the emergency room. So they may be totally asymptomatic. Their first presentation is an anaphylactic event, and they get referred in. We see a number of those every year, and we make the diagnosis. ERs typically don't order a lot of other tests, but they are often on the front line of seeing these acute events that can be life-threatening. So that's a pathway that we see. For primary care providers, if they have patients that have recurrent anaphylactic events that are unexplained, again, that would be another common pathway for an allergist predominantly to help sort out. From endocrinology, again, patients with SM are high risk for low bone density. So we get a number of referrals every year for osteopenia in a young adult. You just totally would not expect, especially young men. So that, again, many endocrinologists will check a serum tryptase level as a screen, and if elevated, send that information along with the patient to see us. So again, very astute to recognize that that's unusual and that could be a sign of SM. If they dig a little further, those patients have history of other symptoms that may really raise the index of suspicion. Similarly, in gastroenterology, many patients with SM have chronic gastrointestinal symptoms, abdominal bloating, chronic diarrhea. And again, in the context of other symptoms, flushing, itching, plus or minus anaphylaxis, that's a trigger. Hey, this patient is not a typical patient that I see in gastroenterology. And they may have some suspicion for SM. So those patients get sent in. So we get lots of referrals from a variety of specialties, and we're very grateful to have that team in place to work together to help those patients. After we see these referrals from multiple specialties, we obviously keep working with those individuals that really help manage those patients. because every specialty has something a little different to offer. So, I have a list of medications whether it be anti-mediated therapy or TKI therapy, but each specialty, whether it be dermatology or gastroenterology, they have their own types of medicines to treat those particular symptoms that I may not be as skilled at or as aware of to really prescribe. So having those team members in place is very valuable. Similarly, with bone health issues, having endocrinology on board to help manage those osteopenia, osteoporosis patients is extremely helpful. We each try very hard in our own specialties to keep up with the latest and the greatest, and that's hard to do across specialties. So having this multidisciplinary team in place is extremely helpful for me and obviously very beneficial for our patients. In terms of working with such a team in our practice, I would say for ISM or non-advanced SM, typically an allergist would kind of be the primary point person to coordinate care. We're typically the ones making decisions in terms of symptom management, and then whatever sequelae of those symptoms that is not being adequately controlled with what we're doing, we obviously seek counsel from our multi-specialty team. So it takes a lot of close communication, maybe lots of phone calls. Good communication is key. Sharing information is key. So, I don't want to just have a general question. You want to form relationships where we're really discussing this particular patient's specific issues, so that we can form a personalized plan for this particular patient. And so I've generally found these teams to work quite well together. We're all vested in the same outcome, which is the best outcome for our patient. And we all learn from each other. So that's really also very gratifying that I'm always learning tips and pearls from my other colleagues. In terms of routine monitoring, I generally, if they're well controlled with ISM, I generally follow those patients on an annual basis. We get basic laboratory studies, including CBC, metabolic panels, tryptase levels, and KIT and VAF levels. We're just trying to monitor for any evidence of progression. This obviously complements any imaging that may be necessary to follow organ involvement, and obviously history and physicals. We always follow DEXAs every 1 to 3 years to monitor bone health, depending on the findings from previous scans. If you have smoldering disease, then we often check you more often, maybe every 6 months, because you have a somewhat higher risk of progression to advanced disease. If any of these laboratory measurements are changing for the worse, especially if there's progressive increase in tryptase or KIT VAFs, then we get concerned that you may be progressing your disease. So that may entail more frequent monitoring and or repeat bone marrow biopsy, depending on the situation. When we start therapy with avapritinib, we again typically start on FDA label at 25 milligrams daily. In terms of monitoring, we generally monitor every 3 and 6 months after drug initiation, and we check your CBCs and metabolic panels. This is really out of precaution, even though there are no significant safety signals seen with avapritinib in the Pioneer trial or in long-term follow-up. It's still relatively new, so we just kind of follow those labs as a precaution. If after 6 months things are pretty stable, then we will spread that out perhaps once every 6 to 12 months. We also follow tryptase levels, again, to monitor evidence that the drug is doing what it's supposed to do. Thank you so much for joining me today. I hope you found this video useful to you as a clinician or as a patient looking for more information about your disease. If you would like a more in-depth look at non-advanced SM, please review the 60-minute accredited CME program, which can be found at www.exchangecme.com.